Pruritus. Letter of Referral. Dear Dr. Mr. Percy Potts, aged 78 years. Thank you for seeing this retired gardener who has a 2-month history of intense generalized itching that is unresponsive to topical steroids. He is otherwise in fairly good health and cares for his wife who has dementia. Yours sincerely. Introduction. The first point of assessment is to decide whether the itching is accompanied by a rash. The differential diagnoses then fall into 2 largely distinct groups, Table 4, which can be further dissected on the basis of a good history and examination. History of the presenting problem. If the pruritus is associated with a rash, then the history should start with a description of the lesions, their distribution, and their timing. Relevant temporal associations that should be explored include those related to drug ingestion, seasonal deterioration, e.g. ultraviolet or pollen, or foreign travel. Could this be scabies? Ask if there are other affected individuals in the same household or if there has been any exposure to potential sources of infestation. Are there any associated clinical features from the history, such as deeper swellings, that might suggest angioedema? Specifically explore whether there is a history of blister formation, which may not be present at the time of examination because of blister roof removal by scratching. Ask about oral symptoms that may suggest lichen planus or an immunobolus disease. Other relevant history. A full functional inquiry should follow, with particular emphasis on features that might suggest anemia, thyroid disease, hematological malignancy, renal or liver impairment. Inquire about the patient's past medical history, including a history of atopic disease. Drug and alcohol ingestion are also vital parts of the assessment of possible causes of generalized pruritus. Family history is also clearly important, e.g. in suggesting a possible atopic diathesis or susceptibility to anemia, hematological malignancy, thyroid disease, renal or liver disease. NB. Pruritus in the absence of a rash can indicate a serious underlying disease, including malignancy. In the history and examination, you must search for relevant clues. Pruritus examination. General features. Skin disease is frequently a sign of systemic disease. From the end of the bed it is worth considering a number of possible causes of pruritus, see Table 4, in order to detect any gross signs of anemia, thyroid disease, renal or liver impairment or hematological malignancy. Cutaneous examination. The first decision to make is whether the pruritus is associated with an underlying rash or is separate from any secondary changes, e.g. excoriation. If there is a rash, then the most useful starting point is often an assessment of the distribution of the lesions. Distribution. A full cutaneous examination should be performed, but particular attention should be paid to disorders with a characteristic distribution, e.g. eczema, flexures, scabies, web spaces and genitals, Fig 22, dermatitis herpetiformis, extensor surfaces, especially the elbows and knees, lichen planus, wrists and mucosae, or pityriasis rosea, trunk. NB. Scratching and rubbing of normal skin can lead to secondary changes that may mislead the unwary into diagnosing a primary skin disease. Look for linear excoriations and nodules that spare areas which cannot be reached, e.g. the central back, Fig 23. Morphology of lesions. Following an assessment of the distribution of the rash, then the nature of the individual lesions should be described according to size, shape, content and color. Many skin conditions have a characteristic morphology, but scratch marks, ulceration, and secondary infection may modify the appearance. Focus on a primary or fresh lesion if possible and describe it as a macule, papule, nodule, plaque, vesicle, pustule, blister, or abscess. Also describe the margins and surface characteristics, focusing on whether the lesion is round-topped, flat-topped, smooth, umbilicated, rough or scaly. In particular, assess whether there is evidence of tract formation, e.g. larva migrans or scabies, Fig 22, blisters or vesicles, e.g. autoimmune bullous disorders or acute dermatitis, flat-topped violaceous papules, e.g. lichen planus, grouped excoriated papules, e.g. dermatitis herpetiformis, or wheals, urticaria. Lastly, note the nature of the underlying skin, e.g. generalized xerosis, dryness. NB. In an itchy patient, look closely for signs of scabies that may easily be missed. Are there burrows and nodules in the typical sites? See Fig 22. Further discussion. If there is no evidence of an underlying dermatosis that might explain the pruritus, then it is clearly important to be aware of other causes of generalized pruritus such as anemia, thyroid disease, renal or liver impairment, or hematological malignancy, see Table 4, and to know what to examine for within the other relevant systems. Finally, after other options have been excluded, remember that pruritus can be associated with psychiatric disease. Plan for investigation and management. This will depend on whether there is a rash associated with the pruritus. Clearly, if a rash is present, then investigations will focus on relevant potential precipitants. If the rash is eczematous, then it might be reasonable to consider patch testing. If there is a history of blister formation, then an immunobullous disease such as bullous pemphigoid needs to be excluded. Scabies mites can be identified by light microscopy of the tract contents. If diagnostic uncertainty remains after clinical assessment, then it may be appropriate to proceed to a skin biopsy. If there is no rash, then appropriate investigations would include blood tests for FBC and blood film, ferritin, B12, folate, C-reactive protein/erythrocyte sedimentation rate, thyroid function, and liver and renal function. If there are other clues from the clinical assessment or initial investigations, then more detailed specific investigations will be appropriate, e.g. full anemia, renal or liver workup. A specific treatment plan may be suggested based on the clinical diagnosis and investigations. For symptomatic treatment, start with bath oils and emollients, particularly if the skin looks dry. Pruritus caused by dry skin is common, particularly in the elderly. Antihistamines can be helpful, with tricyclic antidepressants or phototherapy sometimes used if these fail. NB. Pruritus is commonly caused by dry skin, recommend bath oils and emollients. In most cases it will be appropriate to review in 3 months to assess response unless there is anything to suggest that more rapid reassessment would be warranted, e.g. if underlying malignancy is a possibility. Further discussion. As well as establishing an appropriate management plan for the patient, there may be other issues to explore dependent on the likely cause. For example, if scabies is diagnosed, then sources of infection, and potential for reinfection, should be addressed. If this is in the setting of a group such as a nursing home or hospital ward, then it is important to involve the local infection control team to limit disease spread. Does this man's demented wife ever attend day centers or nursing homes for respite care? Institutions such as these are a common source of scabies and not all affected patients itch. Reactions to drugs can be extremely difficult to disentangle, particularly as the timing and nature of reactions is so variable. The fact that many patients are on multiple therapies complicates matters further. If a drug reaction is diagnosed, then it may be helpful to involve the GP with staged monitored replacements of the drugs, starting with the most likely precipitants.